Well, good afternoon. This is Mark Skidmore, and I'm the director of the North Central Regional Center for Rural Development. And so today's webinar is entitled Deaths of Despair in Pennsylvania and Beyond, a demographer's take on drug, alcohol, and suicide mortality. Many of you were on an earlier version of this presentation some weeks back when Shannon was in the midst of her presentation, and there was an IT glitch. Apparently, some work at Penn State University on the IT side cut her off, and so she was unable to finish the presentation. Shannon was kind enough to reschedule with us and kind of give us a review of what she was talking about, and then complete the presentation. And I know that many of you were on that webinar several weeks back. So I'm not going to spend much time describing the presentation and what's happening. I think most of us are aware that the rate of increase in mortality from drug poisoning, alcohol poisoning, and suicide has increased dramatically over the past 15 to 20 years. And so Shannon is back, and she's an assistant professor at of rural sociology, demography, and sociology, and a research associate in the Population Research Institute at Penn State University. She's also a fellow at the Carsey School of Public Policy at the University of New Hampshire. Her work explores how economic, social, institutional, and policy factors are related to health and health disparities in the United States. I want to remind the participants that if you have thoughts or questions, you can type them in the chat section and we can see them, and Shannon may respond to your questions along the way or wait until the end. So without further ado, Shannon, thanks again for making time to complete your presentation. We're really glad you're here.
Thanks, Mark, and thanks to those of you who are joining again. For those of you who were on before, some of this will sound familiar to you. And for those of you who are new, thanks for joining on. I just want to start out by acknowledging my funders for this project and saying that the views expressed here are not necessarily those of the funding organizations. So a brief outline here. What I'm going to do is talk a little bit about some trends in drug, alcohol, and suicide mortality in the U.S., these sorts of deaths of despair over the last 15 years or so. And then I'm going to talk a little bit about the demography of these deaths of despair, how they vary by demographic group and across the U.S. spatially. Go into a little bit of how we got here, both the kind of spark and what I refer to as the underlying kindling that led us to the point where we are today. And then a little bit of what it might take to combat these increases in deaths of despair. So here I show the increase in the number of deaths that are attributable to drugs, alcohol, and suicide since 1999. The unintended drug-induced deaths, which are the green line, those have increased in the United States by more than 3 times since 1999. So they've more than tripled, with nearly 50,000 deaths due to drugs in 2015 alone, which is the most recent year for which data are available. But we already know anecdotally through a handful of states that drug-related deaths and rates of deaths have increased in 2016 and 2017 as well. The death rate from drugs has climbed at a much faster pace than other causes of death, with a growth trend that's now similar to the HIV/AIDS epidemic in the US during the late 80s and early 90s. Suicides have also increased. They're the red line. They've increased by over 50% since 1999. And although suicides by intentional drug overdose are included in this suicide category, as we're going to see in a minute, drug overdoses actually represent a very small proportion of suicides. The majority of suicides are caused by self-inflicted gunshot wounds. Finally, the purple line shows the increase in deaths from alcohol-induced causes. These sorts of deaths, especially deaths from cirrhosis of the liver, have increased by about 70% since 1999. So together, drugs, alcohol, and suicide were the direct cause of death for over 127,000 people in 2015 and for over 1.5 million people between 1999 and 2015. This is another way of looking at the increase in these deaths. But here I break down suicide by whether they were intentional drug overdoses, suicide with a firearm, or suicide by some other cause. And here we can clearly see that suicides by firearm make up the largest contribution to suicide deaths. And then if we add deaths where drugs or alcohol were not listed as the direct cause, but were noted on the death certificate as contributing to the death in some way, then numbers get even higher. And so that's the addition of that pink bar at the top. So in 2015 alone, drugs, alcohol, or suicide contributed to over 157,000 deaths in the US. And between 1999 and 2000, they contributed to nearly 2 million deaths in the US. Over that same period, they contributed to over 75,000 deaths in Pennsylvania. So which drugs are contributing to these deaths? This graph shows all deaths where drugs were listed as a contributing cause. And here we see that the specific drug involved in most drug-related deaths are unspecified or unknown. That's the gray line at the top. But among those that are identified by medical examiners, opioids are the primary contributor to drug-related deaths, especially since the mid-2000s. Opioids include heroin, prescription opioid narcotic pain relievers like oxycodone, hydrocodone, morphine. They include methadone, and they include synthetic opioids, the most commonly of which we've heard of lately is fentanyl. Even though the US makes up less than 5% of the world's population, we consume over 80% of the world's prescription narcotic opioids. So we consume a lot more relative to our population than other countries in the world. The synthetic opioids, which include fentanyl, are really highly potent and very deadly. Fentanyl is 50 to 100 times more potent than morphine. And we can see from this chart a major increase in the share of drug deaths involving heroin since 2010, and a major increase in synthetic opioid-related deaths, that's fentanyl, since 2013. I also want to mention that although they get less attention from the media and from politicians, the share of deaths that include benzodiazepines as a contributing cause have also been increasing. Benzodiazepines are sedatives. They're commonly used to treat anxiety, panic disorders, and to help with sleep. And we have a growing problem with those as well. Now, the countervailing message in the media has been that addiction does not discriminate. And though that's technically true, it's also true that certain demographic groups that are higher risk than others, and that rates of death from drugs, alcohol, and suicide are higher in certain geographic areas than others. And this really has implications for how we should think about prevention and treatment. Let's take a look at some of this variation. It's important to consider how mortality rates vary by age group. So drug-induced mortality rates are lowest for the 15 to 24 age group and have somewhat leveled off since the mid-2000s for that age group. The drug-induced rates are the highest for the age 45 to 54 age group, but rates for the next two cohorts down, 25 to 34 and 35 to 44, are quickly catching up. Trends are a little bit different for alcohol-induced mortality. So for alcohol, the age 55 to 64 age group has the highest mortality rates. And that really makes sense because the majority of these deaths are due to cirrhosis of the liver, and the risk of cirrhosis increases with years of heavy drinking. It's really noteworthy how much of an increase there's been in mortality for this age group since 2008 as it relates to alcohol. These are the baby boomers, and these trends sort of suggest that that group may have been a group of heavy drinkers in young to middle adulthood. Finally, like drug-induced mortality rates, suicide rates are also highest among the 45 to 54 age group, followed closely by the 55 to 64 age group. And suicide mortality has increased for all age groups since 1999. We can see from this chart that breaks down drug, alcohol, and suicide mortality by sex and by race, that not only are drug, alcohol, and suicide mortality rates higher among whites than among Blacks and Hispanics, they've actually increased among whites while dropping among Black and Hispanic males. Rates for Black and Hispanic females are quite low. Now, this is a demographic and epidemiological conundrum, really, given that Blacks fare collectively worse on several key health measures and they face considerable economic disadvantage. Lower drug-related mortality rates among Blacks, for instance, may be related to physicians being less likely to prescribe opioids to Black patients, but Blacks also have lower alcohol-related and suicide mortality rates, and they have lower rates of depression and anxiety than whites. So something else is going on. These graphs show drug-induced mortality rates and alcohol-induced mortality rates and suicide rates by metropolitan status. The purple line represents large urban, orange represents small urban, and green represents rural. Large urban counties are those that are located in a metro area of 1 million or more residents. These are places like Los Angeles County, San Francisco, Washington, D.C., Broward County in Florida, and certainly Philadelphia. Small urban counties are those that are located in a metro area of less than 1 million residents. These are places like New Haven, Connecticut, or Albany, New York, or Dayton, Ohio. And then rural are all the other counties that are not located within a metropolitan area. Here we can see that drug mortality rates, alcohol mortality rates, and suicide rates are highest in non-metropolitan and small urban areas, and they're lowest in the large urban areas. Drug-induced mortality rates are particularly interesting because until about the mid-2000s, they were higher in large urban areas than in small urban and rural areas. But since that time, rates have gotten much higher in small cities and rural areas in the U.S. This map shows the distribution of high versus low drug, alcohol, and suicide mortality rates by county. So light yellow are the lowest rates and dark red are the highest rates. What we can see here is that rates are comparatively higher in places like New England, Appalachia, the Upper Rust Belt, Oklahoma, the Desert Southwest, Mountain West, Northern California, and the Pacific Northwest. Within Pennsylvania, the counties with the highest rates are Fayette, Susquehanna, Philadelphia, and Cambria counties. And this is over the period 2006 to 2015. And so for 2015, 16, 17, those counties with the highest rates change a little bit. So how do we get here? Well, what I suggest is that the stage has actually been set for quite some time, and we likely would have seen increases in alcohol and suicide mortality even without major increases in drug mortality. But widespread drug availability, especially the emergence of powerful and really addictive opioids, was the spark that started the fire. So in any discussion of opioids, it's important to understand why they're so addictive, and it has to do with the morphine molecule, which is the main ingredient in opioids. It fits lock and key into the receptors that we have in our brains and spines and gastrointestinal tracts, and those mu receptors are designed to create pleasure sensations, and they're especially receptive to the morphine molecule. One of the problems with opioids is that because we're introducing this synthetic pain reliever into our bodies, the body soon begins to shut down its natural production of pain relievers. And so when a person tries to stop using opioids, the body goes into withdrawal. And that's really when physical dependence can occur. And that's one of the biggest problems as it relates to overdoses, is that when a person does kick it, they must always go back to it. And when they do, the body can no longer tolerate the dose it used to tolerate. And that's why the user overdoses. Opioids really don't follow the same rules as other drugs because they fight really hard to stay in our systems. Opioids weren't always widely prescribed for everyday chronic pain. They were once reserved mostly for traumatic injury victims and terminal cancer patients. Beginning in the 1990s, pain advocates really pushed to get pain recognized as the fifth vital sign in the US, arguing that it was just as important to measure pain as it was to measure body temperature, pulse, respiration, and blood pressure. And the thought really was that doctors should ask patients about their pain and medicate them for it. Then in 1996, Purdue Pharmaceutical Company introduced Oxycontin, which was an extended release oxycodone product. Purdue heavily marketed Oxycontin for everyday pain in a way that was really unprecedented for a Schedule II drug. Purdue encouraged their sales reps to aggressively market to physicians, especially in places where other opioids were already being heavily prescribed. And so these were places with a lot of manual laborers, mining areas like Appalachia and the Mountain West, and places with retirees like Florida. Purdue, as many of us now know based on media reports, claimed that Oxycontin was less addictive than other opioid products, and it didn't provoke withdrawal symptoms because its time-release formula would allow for delayed drug absorption. And that really made physicians comfortable prescribing it for a wide range of chronic ailments, from back pain to headaches to menstrual cramps. But what we now know is not only was Oxycontin far more potent than other painkillers, but addicts quickly learned they could crush and liquefy and inject the tablets to experience the full dose at once. Now, some physicians remain skeptical about using opioids to treat chronic pain and remain fearful of addiction risk, but others began to prescribe very liberally. And then even others viewed the increased demand for prescription opioids as a sort of entrepreneurial opportunity. And that's where pill mills really came onto the scene. So those are places where doctors would dole out prescriptions for Oxycontin and other opioids like ATM machines without much diagnosis or follow-up, and patients would line up and they'd pay several $100s in cash to leave with hundreds of pills. Some of those they'd use themselves, but most of which they would sell to others in their hometowns. These clinics first popped up in Ohio, Kentucky, West Virginia, and then they spread across the country. They were especially prevalent in small cities and towns. At one point in Florida, Broward County in particular, there were more pill mills than McDonald's. So earlier we saw this graph showing an uptick in the percentage of drug-related deaths that involve opioids, and we especially see a major uptick in heroin and synthetic opioid deaths. So some experts suggest that as people who were addicted to prescription opioids began to have more difficulty accessing them, some turned to heroin. And heroin is really riskier than prescription opioids because the batches are inconsistent and they can be laced with fentanyl. And so I think it's important to consider how the role that fentanyl plays. And in Pennsylvania, Pennsylvania ranked third for the highest fentanyl confiscations in the country in 2014. So in Pennsylvania in particular, fentanyl contributes to a lot of opioid-related deaths. It's important to consider the age variation in heroin-related deaths versus the prescription opioid deaths. And so heroin use is much more common among young adults than among older adults. So when we break down overdose deaths by age group and we examine the drugs involved in those overdoses, we see that heroin is present in a much larger percentage of young adult overdose deaths, where prescription opioid pain relievers are present in a larger percentage of middle to older age drug overdoses. So the reality is many physicians are still quite hesitant to prescribe opioids long-term to young and seemingly able-bodied adults. So what happens in some cases with young adults is that they might receive an opioid prescription from a dentist for something like a wisdom tooth extraction, or they might be prescribed opioids for some surgery or some injury. And when they might only need a week's worth, the doctor sometimes gave them a month's worth, and they took them all, get hooked, and then they might not be able to get opioids from a physician long-term. So that's a group that may be more likely to turn to heroin. Some young adults also get hooked on opioids just by experimenting with their friends. Their friends have pills, they take some. After a while, they get hooked. Prescription pills are really expensive, whereas heroin is really cheap. In Pennsylvania, for instance, heroin is cheaper than a six-pack of beer. So that's the spark. Widespread availability of opioids was the spark. But deaths from other drugs have increased, suicides have increased, alcohol-induced deaths have increased. And these are not a random collection. Drug, alcohol, and suicide deaths often derive from depression, hopelessness, chronic pain. And what's especially striking about these three causes of death is that they've increased during a period of declining mortality from other major causes of death. So while opioids may have been the spark, I argue that social, economic, and political factors were really the underlying kindling. And this is illustrated in Sam Quinones' book, Dreamland. To many politicians and to the media, this epidemic seemed to have come out of nowhere, but in writing about it, Sam Quinones shows that prescription opioids and heroin, problems with alcohol and mental health didn't just appear in small town and rural America overnight. He said this was not new, it had been happening for 15 years, and nobody paid attention to it until it started to spread to more affluent areas. Ultimately, the U.S. despair problem is driven by this complex interplay of globalization, industrial restructuring, inequality, and economic policies that really emphasize the market over collective safety nets. In two other recent books, J.D. Vance and sociologist Arlie Hochschild describe long-term economic decline, cynicism, anxiety, stagnation, and slippage among largely working-class white communities. So in writing about manufacturing loss and economic decline in Ohio, for example, J.D. Vance states years of decline in the blue-collar economy manifested themselves and the material prospects of Middletown's residents. And the Great Recession and the not great recovery that followed has hastened Middletown's downward trajectory. But there was something almost spiritual about the cynicism of the community at large, something that went much deeper than a short-term recession. In writing about economic prospects in rural white Louisiana, Arlie Hochschild wrote that since 1980, virtually all of those she talked with felt on shaky economic ground. They felt that society was unfair, the economy was unfair, and this led to anxiety, economic stagnation, and even slippage, this sort of a downward mobility in these places. So, are drug, alcohol, and suicide mortality rates higher in places that are more distressed? What this bar shows is that the average county level drug, alcohol, and suicide mortality rate is higher in places with higher economic distress. So this shows the average rate across quartiles. Quartile 1 is the lowest level of economic distress. Quartile 4 is the highest level of economic distress. And here we clearly see that counties that are in the top half of economic distress have significantly higher drug, alcohol, and suicide mortality rates. And across all indicators of economic distress that you can come up with, the pattern holds. So this compares the average drug, alcohol, and suicide mortality rate between counties with the lowest level of distress and counties with the highest level of distress across all these various indicators. We can see that these rates of deaths of despair are higher in places that are more distressed as it relates to poverty, the disability rate, unemployment, the uninsured rate, single-parent families, percent without a college degree. I can add other indicators on here that I've looked at, including the percent that are separated in divorce, the percent receiving public assistance, low self-rated health, higher rates of obesity. These are places that all have higher drug, alcohol, suicide mortality rates. Much of the story about the downward slide of small cities and towns in the industrial Midwest, Appalachia, New England, has been about losses in manufacturing and natural resource industry jobs like mining and logging, because either no new jobs came in to replace them, or the jobs that did replace them were lower paying service industry jobs. And so, in fact, median household income has declined for a really large proportion of counties in the US since 1980. And it wasn't all attributable to the recession. In about a quarter of US counties, median household income declined between 1980 and 2000. And what this chart shows is that average drug, alcohol, and suicide mortality rates are much higher among counties where median household income declines. Many people in these places earn less income than their parents. They see an even less bright future for their children. And there's a real sense in these places that the American dream is sort of a scam and no longer realistic for most people. And we have to remember this isn't something that happened all of a sudden. It's been building for at least the last 3 decades. There are conditions within communities that can protect or buffer against these deaths of despair. Health promoting institutions can play that sort of role, especially institutions that promote social capital, places where there are opportunities for people to interact, facilitates engagement with their neighbors, gets people out of the house, increases interaction. So places that have higher presence of these social capital promoting institutions have lower drug, alcohol, and suicide mortality rates. On the other hand, places that are primary healthcare shortage areas or mental health care professional shortage areas, those places have higher drug, alcohol, and suicide mortality rates. So part of this story has been especially about the increase in drug, alcohol, and suicide mortality among whites, especially young adult and middle-aged whites. The Princeton economists, Case and Deaton, have written quite a bit about this. And my data show the same pattern. And so what is all this about? Why this increase in drug, alcohol, and suicide mortality rates among whites, especially young adult and middle-aged whites? Well, the Pew Research Center regularly conducts surveys about optimism, and that allows for comparisons over time. And in this survey, they asked people ages 25 to 54 to rank their standard of living compared to their parents. Whites without a college degree are far less likely than Blacks or Hispanics without a college degree to indicate that their standard of living is much better or somewhat better than their parents. In addition to that, the perception of doing better than their parents has drastically fallen off for whites since 2000. And so what I think this means is that we need to think about reference groups. When we think about how we're doing in life, we often compare ourselves to our parents. This means that many non-college educated whites are comparing themselves to a previous generation that had more opportunities than they had. A generation where people without a college degree could get decent paying jobs, even if those jobs were often dangerous and very physically demanding, and of course they were. Blacks and Hispanics, on the other hand, might be comparing themselves to a generation that had fewer opportunities. So what this means is that whites are likely to compare themselves to a reference group that leaves them feeling worse off about their lives, whereas Blacks and Hispanics might be comparing themselves to a reference group that makes them feel better off. And so even though it's the case that whites, even those without a college degree, continue to have better economic prospects than Blacks and Hispanics, there's been a significant decline among whites over the past 20 years, especially among those, or maybe just among those without a four-year college degree. Let's take a look at Luzerne County as an example of this sort of trend. The number of manufacturing jobs in Luzerne County has declined from over 42,000 in 1980 to less than 19,000 now. And the types of manufacturing jobs that are available now just don't pay as well as the manufacturing jobs that were around 40 years ago. The poverty rate is certainly not the highest in the state, but it has been increasing. Median household income has basically remained stagnant there since 1980, while the cost of living has increased. Over a quarter of the residents who are in prime working age, between the ages of 25 and 59, are either unemployed or they're not in the labor force at all. Luzerne, home to Wilkes-Barre, suffers from chronic outmigration of young adults, and those who are most likely to leave are those who have the resources to leave, and that leaves behind larger concentrations of the most vulnerable and the most disadvantaged. The number of drug overdose deaths in Luzerne County has nearly tripled in the past 15 years, but it's not just drugs. Suicides by causes other than drugs have also more than doubled. So what's going on there is really bigger than drugs. In these types of places, jobs and the dignity of work have been replaced by hopelessness, frustration, the feeling that America isn't so great anymore. Work is really a source of status in the US. Our identities here are wrapped up in our jobs. But the working class in our country, people without a college degree, people who work in blue-collar jobs, they regularly receive the message that their work is not important and that they are irrelevant and replaceable. That message is delivered to them through low wages, declining health and retirement benefits, government programs for which they don't qualify but for which they pay taxes, and the seemingly nonstop message that everyone should go to college. So it may not come as a surprise to some of you that despite Luzerne County being a solid blue, solid Democratic county for several years, a county that went for Obama twice, Luzerne County flipped to Donald Trump in the last election, and in fact, it accounted for about 59% of Trump's victory margin in Pennsylvania. Luzerne is really symbolic of these types of places in the industrial Midwest, Appalachia, New England, with similar sorts of economies, similar sorts of demographic populations. These trends were present in this election across these types of counties. These deaths represent only a tiny fraction of those who are suffering from substance abuse and mental health diseases and disorders, and the effects really ripple beyond the individuals who die to include families, friends, first responders, service providers, employers. We're seeing major increases, for instance, in children who are removed from their homes because their parents are addicted to drugs. Workplace productivity suffers when workers aren't performing at their best due to drug and alcohol problems. First responders and emergency department personnel are overwhelmed by overdose calls. These are really costs to all of us. I've heard anecdotally that employers in some of the places hit hard by drug use are having difficulty finding employees who can pass drug tests. Sam Quinones writes about this in Dreamland too, and he notes that simply bringing jobs back to these places won't be enough to make them great again or to reduce these deaths of despair if the residents who live there aren't fit for work. These kinds of places, these landscapes of distress and despair are going to require massive investments in drug treatment and mental health services, simultaneous investments in long-term prevention strategies, economic development, as well as strategies to increase social interaction, social cohesion, social trust. So where do we go from here? Well, I'm going to say up front that I'm not a prevention policy expert, nor am I knowledgeable about treatment. I'm a demographer. So what I have here is really based on evidence-based research. Any chance at combating this surge in death of despair, I think, is going to require a widespread, comprehensive approach that deals with prevention, treatment, and recovery. So far, efforts at quelling the supply have focused on opioid prescriptions, for instance. Um, and another effort at quelling the supply has been to try to reduce the drugs entering the border, the Mexico-U.S. border. And President Trump, for instance, has suggested that a border wall will reduce the supply of heroin entering the U.S. But recent news stories show that people are now making synthetic heroin in labs right here in the U.S. I have a colleague who's in North Carolina, and there was a big story that just broke about how several acres of poppy plants were just seized. So people are trying to make heroin and being successful at it right here in the U.S. In addition, fentanyl, which has contributed to a major surge in drug overdoses in the past couple of years, comes from China, not from Mexico. So efforts at reducing supply are going to be fruitless as long as demand remains high. And that means that preventing drug initiation, especially among youth and people who are coming into adulthood now, that's going to be key to reducing abuse and mortality among those cohorts. In terms of treatment, the most commonly adopted strategy has really been to increase access to Narcan, but this isn't really a treatment strategy. Narcan is an opioid overdose reversal drug. And it's an important step, and it's an important piece of the overall puzzle. People certainly need to be alive in order to recover, but it's only one small piece, and by itself, it's barely going to make a dent in overdose deaths. We're simply not going to Narcan our way out of this because the problem is bigger than opioids. Narcan is only effective for opioid overdoses, not for benzodiazepine overdoses, for instance. And Narcan certainly isn't effective against people abusing alcohol or people who commit suicide with a gun. So related approaches need to include increasing access to substance abuse treatment, including medication-assisted treatment, comprehensive patient treatment approaches, and even harm reduction approaches, which have shown some promise, but they're controversial because they're aimed at reducing the negative consequences that are associated with drug use rather than extension altogether. Finally, we need to remember that recovery is really a lifelong project. A person isn't cured after treatment. And to better understand and deal with substance abuse recovery, I think we need to view substance misuse relapse similar to how we view relapse for other chronic diseases like diabetes and hypertension. When people fail to take their medications as prescribed, or they don't exercise as directed by a doctor, or they fail to change their diet as directed by a doctor. So key to this is acknowledging that opportunities and choices and behaviors don't occur within a vacuum. They exist within a context of larger social structures like our families, the economy, the education system, healthcare systems, political systems, and social safety nets. So going forward, we need to come to terms with the fact that what we're seeing here is bigger than opioids. Opioids are a canary in the coal mine. They're here in our face, in the media, from politicians, maybe even in our own families every day. We hear about them nonstop. But the opioid problem is simply a symptom and a symbol of much larger social and economic problems. We need to recognize that health is a function of more than public health policies. Economic and social policies also influence health outcomes. That means that good economic policy, good criminal justice policy, good social policy will also be good public health policy. Our individualistic go-it-alone attitude in this country is certainly not helping. I think this picture of the sailboat rowboat is actually really telling. With the people huddled on the one end, it's not sinking, saying, thank goodness the hole's at their end, while the others at the sinking end are trying to bail everything out. We're a very individualistic country here in the US. Whites in particular embrace the ethos of individualism, which may partly explain such high rates of death and despair among that group. When things start to fall apart, going it alone just doesn't work. And this idea that we're all in this by ourselves and that only the strongest survive contributes to isolation and despair. The reality is the consequences of deaths of despair affect us all, whether we personally know someone who is dealing with addiction or mental illness or not. This is a population health issue. This is an issue related to U.S. economic competitiveness and sustainability. And until we're willing to invest the time, energy, and political will into addressing these underlying causes of distress, despair, disconnectedness, people will continue to engage in harmful behaviors, families and communities will continue to suffer, and the consequences will reverberate to affect us all. So if you're interested in reading more about these trends or potential explanations for these trends, here are some articles that you can link to. I also have links to addiction resources here, and now I'm happy to take questions.
Thanks, Shannon. For the participants, if you have a question, please feel free to type in your question in the chat session and we can take them. Shannon, while we're waiting for comments or questions to come in, are you aware of any studies that look at these kinds of deaths in a cross-country framework? The tone of your presentation is it's much bigger than opioids and prescriptions, and yet I believe there are differences across countries in terms of how much opioid-related pain relievers are prescribed under what conditions.
Yeah, so I'm not familiar with cross-national variation studies, but what I will say is that in countries where opioid prescriptions are much lower, people often substitute with other substances. So, for instance, in hard-hit areas of Europe, economically hard-hit, socially hard-hit areas of Europe, alcohol-related and suicide deaths are up,
right,
even if drug-related deaths are not. And so I think there's really interesting comparisons to make cross-nationally. Certainly, we have the biggest problem here in the U.S. Other countries in Europe have seen increases in spikes, especially during economic downturns. But countries in Europe have a much stronger social safety net than we do. So that often picks up for some of the slack.
Thank you. Well, I see several people are typing. We just have to wait for the questions to pop in.
Okay, so someone's asked about the social capital effect. Michael said, I was struck by your research showing the social capital effect in mitigating opioid deaths. Can you say more on that effect? So the social capital indicator that I've been using is one that measures the number of different types of establishments and communities, civic associations, things like the Elks Club or the Lions Club, as well as religious institutions, labor, political, professional organizations, sports facilities, places where people have opportunities to interact and engage with each other. What the sociological research on this really shows is this is the Putnam effect. For those of you who heard about Robert Putnam and bowling alone, this idea that communities are better off, health among individuals and at a community level is better in places that have more of these types of institutions and establishments that allow people to have conversations with each other, get out of their house. And the reasons for that is that not only are they mechanisms of support, but they provide opportunities for building trust. They provide opportunities for discussing problems in the neighborhood and for making people feel as though they fit in and that they have some reason for being. Another question here. For traditional college-age students who originate from areas of despair, but then become college educated, do you find students are less likely to abuse drugs or alcohol, or do you find that where they return to live impacts their mental health state and use of substances? That's an excellent question, and I'm unable to answer that question because I don't have individual level data. There are no national individual level data that tracks people over time. from where they started and where they ended up to determine, did they get sick, did they use drugs, did they die. The data that I used are all at the county level. Another question is, how do you handle if someone has a history, a past history of abusing pain meds, but is having a procedure that pain pill might or most likely be prescribed? I am not a medical doctor. I'm not a treatment or a prescription expert. And so I don't have data at the individual level. I will say that not everyone becomes addicted to opioids, to be sure. Not everyone who's prescribed them develops an addiction problem. In fact, only about 25% of patients who are prescribed opioids long term develop a problem with addiction, which is actually pretty high. But it certainly demonstrates that not everybody who uses opioids will become addictive. Now, this question about people who have a past history of opioid misuse, who then have a procedure where they certainly need a pain pill, that's a tricky situation. I know that doctors are dealing with this issue. And, I guess I would say that one of the things that we should try to focus on in the medical community here is developing pain treatments that are less addictive than those that we have now.
Yeah. Well, maybe
That's
I'll ask one more question, and then we can close things off. So some of the things you discussed were changes in expectations. You have this sort of relative standing, and you see maybe what your parents were able to accomplish and the success they had, and then your opportunities are less, and that this creates, a tension. And I understand that and see it, but I guess what I'm wondering is, there are countries that have a much lower standard of living than we do. So is it something we see in this transition, then it stabilizes once that transition is over? Because our economy is changing, and I hope that we can, really make progress and give a broader swath of the population greater opportunities. But I'm wondering also if once we stabilize and we set into a new set of expectations, if these conditions that we are observing will also stabilize.
Yeah, that's a great question, and I don't know for sure, but what I would say is that for me, that this is a story of downward mobility. That rates of drug, alcohol, and suicide mortality are not all the highest in the most economically deprived areas, the places with the highest poverty rates in the country, for instance. The Mississippi Delta, which has among the highest poverty rates in the whole country, have very low rates of drug, alcohol, and suicide mortality. Where we're seeing high rates of deaths of despair are places that are downwardly mobile, places that were once pretty economically successful, where people without a college degree could earn a really decent wage, have health insurance, get a retirement package, go on vacation, be able to buy a house, even have a couple of cars, and that those jobs just by and large don't exist anymore. Or if they do, they pay much less and they're less economically stable than they used to be. There's that, but then there's also this mismatch between the skills that are needed for these sorts of manufacturing jobs that are available now and the skills of the people who are living in the communities where those jobs are available. So again, for me, it's a downward mobility story much more than a cumulative or persistent poverty.
Okay, I don't see any other questions, and I think we're just about at our time frame anyway, so maybe now's a good place to stop. Thank you very much, Shannon, for the great presentation, and thanks for all the participants, and I think we can sign off for today.